Our final group of diuretics are the drugs that work as potassium-sparing agents. Here we're looking at a collecting duct cell, what is known as a principal cell, which is the target of the hormone aldosterone. Aldosterone as a steroid is released in situations of hypovolemia, but also in situations of hyperkalemia. Recall your endocrine physiology. Aldosterone as a steroid is a lipid-soluble compound. It will enter the actual cell and bind here AR, the aldosterone receptor itself. Aldosterone receptors belong to that biochemical family of zinc finger proteins. These are proteins which, when stimulated, act as transcription factors that will then go into the nucleus and bind to enhancers to change gene expression. Well, aldosterone then, through the changes in gene expression, result in several permeability sites for sodium. Some are simply some sodium channels which are ungated, and as sodium comes in, the change in positive charges inside the cell result in potassium efflux through also ungated channel. Another possibility are sodium proton or sodium potassium antiports. Whatever the case might be, through the action of aldosterone and its changes in gene expression, sodium will be retained, so will be water, to the expense of potassium and protons. What we propose to do then as a weak diuretic is to actually go and block the aldosterone receptors themselves. This is the effect of drugs such as spironolactone and its little cousin eplerenone. Now, these are the primary drugs to know at this point, being that we know that they will also be used beneficially in a congestive heart failure patient. The other approach listed under that diagram is the blockade of the sodium permeability site themselves by drugs such as amiloride and triamterene. So if you want to add these drugs to your diagram, of course you can do so, or otherwise you can simply look at them underneath the diagram in your text. The intercalated cell, by the way, shows you that this is the spot in our kidney where we have titratable acid production. It's a place that is quite relevant for the excretion of ammonia, if you remember, since ammonia, NH3, once combined to the proton, becomes ammonium, water-soluble, and excretable by our body. Well, here is the spironolactone. Spironolactone, first, as an antagonist, has zero efficacy. As such, it requires the presence of aldosterone to do its job. So aldosterone has to be elevated if I want to see some pharmacological effect of spironolactone. Aldosterone is, of course, elevated in congestive heart failure. Let's remember that when we decrease the cardiac output, the actual kidney, through renin and angiotensin, will sense that drop in pressure and cause aldosterone release. Otherwise, besides this primary use of spironolactone today, which improves survival of Ch06f patients, it has been used forever as an adjunct to potassium-wasting diuretics. Understand this, it is used to correct the hypokalemia of drugs such as acetazolamide, the loop diuretics, or the thiazides. Then you do see a use that is pretty surprising, I'm sure, at first. The use of spironolactone as an anti-androgen. Well, this stems from the fact that as a steroid receptor antagonist, spironolactone is really not selective. It can actually also block other steroid receptors such as androgen receptors. So on one hand, expect anti-androgenic side effect in people who take spironolactone, such as a male using the drug for Ch06f developing gynecomastia, or taking advantage of this side effect and using the anti-androgen as such, maybe a female with hirsutism or significant acne. Common side effect otherwise of any potassium-sparing agent is going to be hyperkalemia and acidosis. Of course, this would be confounded if they're used as adjunct to drugs that cause hypokalemia and alkalosis, such as thiazides or loops. By the way, amiloride and triamterene, this is pretty much their only uses, adjunct to potassium-wasting diuretics. Certainly do not attempt to use them for congestive heart failure. They have nothing to do with aldosterone. The statement that they are used in the lithium-induced nephrogenic diabetes insipidus will be a statement that we'll explore when we review lithium in bipolar disease. So we'll just remain with hyperkalemia and acidosis as a main side effect of these two medications. The final note in this slide deals with the antiandrogenic effect of the drug spironolactone. Imagine this, your older CHF male patient is certainly not happy to run around with breasts, so as such will probably potentially not follow appropriately the treatment and fail complying to it. We need a drug that is more selective of aldosterone receptors. This is the drug eplerenone. Eplerenone is a selective aldosterone receptor blocker devoid of antiandrogenic effect. So here is, to summarize, a table that you find at the end of your notes which focuses primarily on electrolyte disturbances and possibly identifies the diuretic based on this. Imagine a board question giving you the urinary electrolytes as panels in order to identify the drug. First, how would you identify that the drug they're talking about is a diuretic? You remember, by definition, except for mannitol, these are drugs that increase sodium excretion. So what I want you to first highlight in this table is that every single of the diuretics mentioned here will increase urinary sodium. And even if it's very small, it doesn't matter. By definition, if sodium excretion is increased, you are being tested on a diuretic. Fine. So then, based on this, I identified a diuretic. What should be my second point if I'm setting up a system that will allow me to identify the drug? You know, I think your best bet next is to look at potassium. Look at potassium and figure out, is this a drug that causes me to waste potassium, increase urinary potassium, or is this a drug that actually will cause me not to lose the potassium? Indeed, if my potassium is not being lost in the urine, it must be retained. And if it's retained, it must be a potassium-sparing diuretic. So this would be amiloride or triamterene, or drugs such as the aldosterone antagonist, spironolactone, or eplerenone, the drug that has no antiandrogenic effect. By the way, the last column tells you that with that potassium sparing comes the lack of proton excretion, and therefore metabolic acidosis would be measured in the blood. What if then you end up with a drug that causes an increased excretion of both sodium and potassium? Where could you go next? I would recommend you then look at bicarbonate. You see, if you see a large increase in bicarb in the urine, then you've identified a carbonic anhydrase inhibitor such as the drugs acetazolamide or dorzolamide. If you do not see the increased bicarbonate to identify a carbonic anhydrase inhibitor, I think your best bet as point number 4 would be to focus on calcium. So that if you saw that the drug increased sodium and potassium excretion, and also if calcium is lost as a urinary electrolyte, then you've identified a loop. Conversely, if calcium is decreased in the urine, therefore retained by your body, you've identified a thiazide. Following these little guidelines will help you identify diuretics with electrolyte panel. This concludes Chapter 6 on diuretics.